Welcome everybody. It's great to see so many people with us from around the world. Good morning, good afternoon, good evening, wherever you might be. I'd like to introduce Nadia Malliou, who will be speaking to us today about the emotional and psychological impact of axSpA and how patient organisations can best support their communities. Nadia is a professional psychologist with experience in various professional contexts in mental health services and administration. She specialised in chronic pain management and for the last few years has been working with the pain unit at the Thessaloniki General Hospital, and I apologise if I've mispronounced that, supporting patients with rheumatic diseases. Nadia has volunteered with the Hellenic League Against Rheumatism, or ELENA, for the last 5 years. She's involved in chronic pain management, both academically and clinically, through the projects and collaborations of the association. And they include the collaboration with the Medical Physics and Digital Innovation Laboratory of the Aristotle University. I had the pleasure of seeing Nadia at EULAR recently, and she's attended many other congresses around the world representing Greece and ELENA. I will have the opportunity to open the session for discussion following Nadia's presentation. But for now, I'd really like to welcome Nadia.
So, hello everyone. I hope you can hear me. And without further ado, I will share my screen and start with my presentation because we have a lot to talk about today. I hope you will be able to see my screen in a mere moment. Please, someone let me know that you can see that.
We could see it a second ago. Oh, there you go. Perfect.
Okay, so as Joe said, I'm a psychologist. Apart from being an axSpA patient with a lived experience for many years now, I'm also a psychologist and I do work in a university hospital. I'm not going to mention the name. Nobody's going to be able to pronounce it well. So I'm working in a pain unit and I do have experience with chronic pain patients. And I'm here to talk about the emotional and psychological burden of axSpA and the role of patient organizations. And what are we aiming for today? And I'm going to be discussing a little bit about the review of the bibliography. And I wanted to keep it on the scientific side because there is research about the emotional and psychological burden of axSpA, and then talk about a little bit about the vicious circle of pain and give you some things to talk about the role of patient organizations, and then have an open discussion with you regarding today's topic and share, if you will, best practices. And let's begin about the impact and the actual review of the bibliography. And I think you all know the European Map of Axial Spondyloarthritis, EMAS, and what the survey has to give us. And the results show that there is a long diagnostic delay. We've all been talking about that delay and the substantial physical and psychological burden and that indicating important unmet needs for patients. axSpA restricts patients' ability to participate in their daily routine and lead a productive work life. So understanding the patient's perspective can improve both health outcomes and shared decision-making between patient and rheumatologist. And this is very important to understand the perspective of the patient, because this is the only way we can actually help the patient. And regarding comorbidities, there's a lot to be said, and the most common comorbidity in axSpA patient is hypertension and depression. And if you have a long way with axSpA, you may already take medication about both or have taken medication, especially hypertension. This is a quite common comorbidity. This study tried to examine how comorbidities cluster and in axial spondyloarthritis, and whether these clusters are associated with quality of life and other outcome measures. And patients in the depression, anxiety, and fibromyalgia and irritable bowel syndrome clusters reported poorer health and increased axSpA severity. axSpA severity relates to increased disease activity and physical limitations. And moving on, this systematic review described the prevalence of depression in axSpA patients. In any type of patient, like axSpA, ankylosing spondylitis, non-radiographic axSpA patients, this is like all types of cohort patients, and depression is common among axSpA patients and associated again with more severe disease activity and functional impairment. So identifying and managing depression should form part of their holistic care. And this is, I would like to put a star in this particular sentence, because who is the proper person to identify and manage depression in the axSpA patient? Of course, it's not a rheumatologist, and we will be discussing that further on. And this study raised another question to explore the impact of depression on treatment outcomes and axSpA treatment on symptoms of depression. So there is a question on depression in axSpA patients, not only per se, but also in regards to treatment, adverse events, and how this one affects the other. Moving on, the Atlas in Spain. The Atlas was a survey done in Spain, and it tried to assess the risk for mental disorders, again in patients with axSpA, and in relation to sociodemographics and disease status and previous diagnosis of mental disorders. Again, the prevalence of risk for mental disorders was very high. High disease activity is a good indicator for the risk for mental disorders. As you can see, again and again, high disease activity, which in an axSpA patient always translates in higher level of pain and functional impairment, is always in some way linked to depressive symptoms or depression. Another survey, the IMAS survey in US patients, showed that the patients included in this study, over 18 years, 228 of them, reported psychological distress and impaired function. These two were linked. So again, this study showed that substantial delay in time to diagnosis was twice as long in women versus men. This is a socio-demographic, but if you see the reviews and the bibliography, depression is higher in women, delay in time to diagnosis is higher in women. Hence, this could be an connection between those two. Another study had the objective to determine the prevalence of symptoms of anxiety and depression among axSpA patients and explore the underlying associated factors. So people were screened here for disease activity, sleep, fatigue, quality of life, and work productivity. And depression and anxiety were associated here with high disease activity and reduced work productivity. And the authors point out that patients should be regularly screened for these symptoms. But I have to say that, like in Greece, in everyday clinical practice, we do go to the doctor, and high disease activity is always screened via BASDAI, via BASFI. But I cannot recollect any time that a doctor asked me about my work productivity or any type or any symptom relating to my work in any form. So this is something to be discussed or for us to think about. And let's go to the unspoken realities of living with axial spondyloarthritis. And this is a qualitative study on couple experiences living with axSpA. So this is a qualitative study in opposite of quantitative studies that I've already shown to you. And these were telephone interviews done to 9 couples, one living with axSpA, the other not, and they were asked about the realities of the everyday life and the emotional distress experienced of the axSpA. So thematic analysis was done to the data, and three themes were pointed out. One, perceived relational closeness was especially in having to be dominant, like having to, especially from partners talking about dominating daily decisions, like this was impacting their closeness. Playing third wheel to axSpA, even when couples were talking about their leisure activities. I mean, one would think that this would come about when they had to go to work every day, difficult situations like day-to-day routine, but they were talking about that when talking about leisure activities. And tensions surrounding a carer type role were identified. Partners commonly adopted a carer type role, whereas people living with axSpA expressed a desire for a greater sense of autonomy. So, the social context of managing a long-term condition suggests the need for including partners within consultations and a need for support also for the partners apart from the patients living with axSpA. And another issue I wanted to maybe present here to you today was about the sexual quality of life in patients with axSpA. And this study tried to examine the relationship between demographics such as age and sex, disease-related variables, treatment, and sexual quality of life. And as you could imagine, I was like thinking about it, but inflammation in patients with axSpA, even in the biological treatment, reduces sexual quality of life. So inflammation in terms of disease activity, so the higher the disease activity, the less sexual quality of life. And this is also true about sexual relationships in a study about ankylosing spondylitis. So this study tried to explore the impact of AS on the sexual relationships of people living with axSpA. And it was substantial, and the conclusion of the study was that management of AS should be also directed not only to physical outcomes, such as disease activity and physical function, but also take into consideration the psychological state of the patient. So, let me talk about a little bit about the vicious circle of pain. And people living with axSpA, and as I already mentioned in the previous studies, the disease activity and the functional impairment were the two factors impacting the emotional and psychological state of the patient. And disease activity and functional impairment points out to chronic pain. So dysfunctional cognitive schemas like thoughts and core beliefs and behaviors towards pain and disease increase the possibility of developing depressive symptoms, anxiety, and even post-traumatic stress disorder. And in some cases, these symptoms do not meet the criteria of an official diagnostic category to say that someone has depression or an anxiety disorder, but they do have a severe and difficult daily life, and they do have a severe and difficulty in their managing the disease. So what happens in those cases? We do have some barriers affecting people's emotion and people's engaging in managing their disease. One of them is catastrophizing. So this is the focus on thoughts and reactions that magnify the experience of pain. This precedes phobias and leads to increased likelihood of depression and anxiety, greater functional difficulty or disability, lower quality of life, and levels of perceived control over pain. So if a person thinks that everything is going to get worse, if a person thinks that if I'm in a higher level of disease activity, I will not be able to control my life to have a better day-to-day activity, This leads to lower emotional and social functioning, poorer response to pharmacological treatments, and that makes pain management more difficult and reduces physical functioning. And the second barrier is fear and avoidance of pain. So fear of injury and worsening the medical condition, and this is so common with patients living with chronic pain, like patients with axSpA have a pain, especially those that have experienced the delay of diagnosis for more than 1 or 2 years, have this kind of fear because they have been exposed to chronic pain without a proper diagnosis. So they do feel that the medical condition will worsen. They have an increased sense of pain and disability, and they do adopt passive or avoidant strategies. One common avoidant strategy is having less movement in their lives, a lower physical functionality, and this leads to more impairment, and this leads to more depressive symptoms, and this may lead to mental health disorders. And I have to come back and remind you all that the It's All Connected campaign that ASIF did recently, and we did in Greece too, was all about that everything is in a kind of connection, because one leads to the other and the other and the other. And I've given you this figure to showcase that whenever a person injures him or herself, the common way to go with the pain is to the right of the screen. We have the pain experience, no fear, confrontation of the experience, and recovery. But with a chronic pain patient, like an axSpA patient, we go to the left and we have kind of a loop where pain catastrophizing and pain-related fear leads to an endless way of thinking about the pain again and again and again, and we have the patients avoiding engaging in social interactions. We have the patient avoiding engaging in day-to-day activities. So the approach to pain management and to self-management in general has to be biopsychosocial and has to engage all kinds of resources. I am sure that in terms of interventions, you have all, like, in a way, listened or have come across cognitive behavioral therapy and acceptance and commitment therapy, or mindfulness-based stress reduction therapy. These tend to be very effective, but we need to have a committed or an engaged or a motivated patient. So these all target dysfunctional thoughts, and these are ways to support patients. And these are more interventions we can do and we can offer. But I need to stress and need to make a point on asking everyone here, should a patient organization offer psychological support to its members? And trying to find an answer, an official answer, a good answer for all of you and myself, of course, I went to the European Patient Forum and came up with this, the value of patient organizations. One of them is that the role that patient organizations play in the area of peer support consists of providing knowledge, sharing experiences, and offering emotional, social, or practical help to individual patients. It can take a number of forms, such as mentoring, counseling, or listening. So yes, national organizations of patients provide and co-deliver self-management education and develop support for patients. So the answer is yes, patient organizations can offer psychological support to its members, and if you ask me, they should offer. But who should be the one to do it? And the obvious answer is a trained, a licensed psychologist, a counselor, a mental health care professional. And then comes another answer. Do all national organizations have the staff or the ability to offer that resource to their patients? I mean, big ones, large ones, yes, but do small national organizations have the ability? I'm not so sure. So there comes another question. Can a patient with lived experience or a volunteer become a mentor or a peer counselor? And the answer is yes, but only with proper training and supervision from a trained and licensed psychologist, counselor, or mental health care professional, not without training or proper supervision. And does this mentoring work? And I do have a good answer. I mean, a scientific supported answer. Yes, it does work, and it can benefit both the mentors and the mentees and the supporters. And it's proven that it can work very well for I'm sorry, I haven't found any scientific data for axSpA patients in particular. I'm not sure if it's not that we haven't researched axSpA patients. I'm fairly certain that even if we don't have yet, we will in the future. And we can do it even on the internet. This is a program delivered solely through internet for young patients with idiopathic arthritis. And it was a very successful program, the peer-to-peer program, that was connecting mentor to mentee via an application through an internet application that was very successful and very motivating for the people that participated in the program. And going back to my initial question, should a patient organization offer support? I try to find good ways to give you and to answer that question, and I came up with our, I think, best practice of the helpline of Eleana. We do have a helpline that was initially over the phone. It's been going on for 7 years now. And during the pandemic era, we had to become hybrid and to support people not only via the over the phone and on face-to-face sessions, but we became online too, and via Skype, via Viber, via whatever way you can think of, we try to do it. And I'm giving you the statistics of the line for 2021. Half of the calls were about self-management, and half of those calls were about the psychological support that people came to ask and requested help over the phone or over online sessions. And we found out that even post-COVID, the requests about online support remained, and they are now even bigger, to keep it online, to have online support again about anxiety, depressive symptoms. So actually, people do need the support. They do need to have someone supporting them again about issues that have already been discussed. So I will give back to you now the floor, but before, I would like to raise the questions about what do patient organizations have to offer so they can support actually their individual members, and can they do it for groups? And how do your helplines work? I mean, do you have them in your organization, and how do they work? And I hope I was brief enough.
Thank you so much, Nadia. I think you did an amazing job. It was so interesting. And just want to say thank you so much for pulling so much information together. I thought it was really interesting what you're doing as an organisation, in the way that you've moved more to online support post-COVID, but that sounds like that's something that the people that you're supporting are still wanting to engage with in that way. I'd be really interested to hear from others and maybe we can share some experiences about what different organisations do your organisations offer support, and how does that work? I don't know if anyone would like to unmute and share how their organisation works.
I mean, just to keep the ball rolling, I would have to say, because I chose not to mention it on my presentation, just to give a nudge to everyone to talk about it, we do have one psychologist on staff, paid psychologist on staff, and we do have volunteers that we train them next to the psychologist to be able to do it. Otherwise, they wouldn't be able to do it. And they, of course, they are volunteers, so they're not getting paid. And now we do have so many incoming calls that we cannot meet the need. So
thank you, Nadia. Sally, you've just shared something. Did you want to speak to that as well?
Yeah, I can do. I mean, and thank you for your presentation. That was really interesting. Yeah, I've just shared a little video that King's College, we did some qualitative work, and they put the results together in a video so we could share it with our members. And I think lots of the themes are very similar to the things that you discussed. And in terms of the support we give, we do have a helpline. I think people tend to call us much more about practical things initially, but then it does go into how people are feeling. But we don't have training on counselling, and so we have to move people on elsewhere. The other thing which we're doing, which has been really successful, which we just started recently, are just monthly meetups, and people can just sign up, come along. There's usually about 40 people come, and we have a sort of topic, and people just start chatting and sharing things. And I think people are just enjoying it far more than we ever thought they would, and really sharing a lot. And then, you know, we kind of get the ball rolling, but then everyone's just chipping in and offering advice and offering their experiences. And it's been a very easy thing to do. We just do it through Eventbrite and advertise it, and it's been incredibly successful. There seems to be a real appetite to reduce the isolation and talk to others.
Thanks, Sally. And just are those monthly meetups, are they online or are they in person?
Yeah, they're online. We just advertise them through Eventbrite. They're just an hour long, and people come along, have a chat. If they don't feel up for it, they can keep their videos off and their sound off. But we've noticed people come back and then maybe talk at the next meeting.
That's interesting. I think that's one of the nice things about being online, is the fact that if you don't feel ready to share or to really participate, you can sort of be a little bit quiet and have your mic and your camera off, and it's a nice way to, as an introduction. And Andrew, were you going to say something? Well, we can't hear you, Andrew. No, so we can't hear you.
Can I jump in?
Yes, Jo.
I've got a question, and I think it's more from something that Miranda said once. So we've got quite a few organisations on in ASIF's membership that are really new, and they are just little more than a Facebook group, although Miranda's is more now, but they are younger. So when they're starting out, and they might end up on the phone with someone who's really depressed or really in a terrible state, who is it you move people on? How do you deal with that? And who do you move? What should you do?
Nadia?
Well, in that case, I think a good idea is to have two things in place. One is to have an official referral pathway, according to which, I mean, in Greece, we have some official referrals we can do. I mean, we do have public mental health care services offered to people. So we need to know in advance where to refer someone. If it's an emergency, again, we need to know where to refer someone. So if it's someone on the phone saying, I'm like about to hurt myself, you need to be able to know where to refer someone. You say, please go to the nearest mental health hospital now. Because we absolutely have to understand that we are not the proper person to do anything with them. So this has to be very, very clear. We're not there to do anything on the mental health side or situation. So anyone who is doing and answering a phone, in case you encounter someone over the phone who is in shambles and needs absolutely at that moment to speak to someone, you need to be able to refer. So before you do anything, you have to have the referral pathway at hand. So this is 101. Because it's no joke. You say it will never happen to me, but it might.
Yeah.
So you need to know. And it's Greece. I know about Greece. I mean, from any other country, anybody who's like answering a phone should be able to know where and how to refer someone. Simple as that. Even if you don't know how to refer, you say, please call your doctor as soon as possible and refer back to the physician, because it's essential to know how to do that, at least.
Absolutely. Thanks, Nadia.
Yeah.
I know Annie's put a couple of things in the chat about the fact that you have a number of national arthritis organisations and mental health support organisations that you refer people to as well. And you also said, Annie, in the chat that you help people to find clinicians and allied services in their area and access medications and government programmes. So it sounds like your organisation kind of works very well in terms of signposting people. I know we've had a few people's hands up. So Prachi, did you want to go? Because you had your hand up.
I just wanted to present a different point of view. I completely agree to what Nadia said about referring a person to a psychologist. And I was practicing before marriage. I myself am a psychologist, and I was practicing before marriage. And one thing that I've seen very prevalent, at least in India, is going to a psychologist or a psychiatrist is still a very big taboo. So if we, even on call, or if we are talking to somebody and we find that that person really needs some mental help, needs a professional, if we do recommend that, that would escalate the matter in a very wrong way, I would say. The person would not be receptive to what we are saying. It would be treated like, it would not be taken in a good way. So in India, we have to really tread very carefully when we are planning to refer somebody to a psychologist. So normally when we get calls, we tend to talk to them and we tend to listen to them. We tend to provide, although it is very informal, it's definitely not professional. And we would love if that approach changes in India. We definitely understand the value of professional help, but however, that is not the case. And we'd rather have them seek help, even informally, than rejecting help because we are pushing them towards a professional person. So we tend to, if we see that somebody is in immediate need, or they've kind of mentioned something on the group about they don't want to live, or they've just, so we try to find somebody who's very local to them, any volunteer who's ready to go to their place physically and talk to them. So that is one thing that we rely on very strongly, because the people, firstly, they do not have the physical, the financial support to go and meet a rheumatologist or even a regular general physician. So that is a very big problem in India that we face, that people don't go to doctors because of the financial constraints. So if we ask them to go to a psychologist, for A, it is a taboo, B, they don't have the resources. So they do need these informal volunteers who are ready to go there, sit and talk to them, just chat with them, just listen to them, talk to their family members, and let them know that, yeah, we are there. So once that person goes there, talks to them, the person, we've seen that the person relaxes, then they kind of meet regularly and they kind of establish a bond, and that helps them to kind of come out from there. Not, I may not say completely or professionally, but at least not to that extent that they may feel suicidal. So in India, I think that helps. Talking to them helps more than referring them to a psychologist or a psychiatrist. That way, they completely shut us off as well. If we refer that, they stop talking to us as well. So we tend to tread very carefully over there.
Thanks for sharing that, Prachi. And I guess it's, it's very different in different countries, and, the way that people have access to different, psychologists or counsellors or medical professionals or whatever. Just a quick question, Prachi. In terms of the people that you get to go and see people who you suspect need some additional support, are they trained in any way, or are they simply volunteers?
No, absolutely. They're all informal volunteers. They're not trained, but they go more as peers and people are more receptive because that person has gone through the same journey. So they kind of talk to them and tell them that, yes, the place that you are in now, we were at the same place earlier. Then we have those WhatsApp groups where people are still talking and pushing and motivating them. So that provides a big support to them. And again, not only if we are in urban part of India, maybe the people may be receptive for psychological help, but in semi-urban, rural, absolutely. I mean, I forget about being open to it. Maybe they do not have a psychologist nearby. So that is a very far-fetched thing at times. So we have to rely on these informal people. And in India, generally the bonding, that informal communication has a very strong bonding, because people like to talk to people personally, share their things. So that bonding is much more stronger, and the community bonding is much more useful and emphatic than any formal bonding.
Yeah.
So
No,
those people are not trained, but because they share their journey and they are there and they kind of cheer that person up and just kind of talk to that person in their lingo and how they want to listen, most of the people generally tend to feel better after that particular phase.
Thank you, Prachi. I guess, as you say, it's different. I'm not sure. I think in certain countries, there's a sort of degree of needing to ensure that there's some kind of training or whatever, purely because I'm just thinking that some countries are more litigious than others, and you have to be very careful from that perspective as well. So just interesting. Nadia, did you want to respond to that?
Yeah, and there is when people call, especially then when they are over the phone, calling up asking for advice or help, the discussion could go very, very wrong, especially when they say, like, for example, this is a true story, no true names will be mentioned, of course. I've heard on a Facebook group that this medication can help me sleep at night, and I've started taking it, and this is a psychiatric medication, and you know that it's off the counter, you can buy it in any drugstore, and it's without any prescription, and no psychiatrist is overseeing the medication, and it's being discussed with a psychologist like myself over the phone. This is a very tricky thing to be discussing over the phone, not because of the legality of the issue, not because you think or you may get in trouble, because of the actual thing happening, because this patient is taking an off-the-counter medication, maybe not suited for this particular person or not suited for this particular situation, without prescription, without supervision of a doctor, it's so complex what is happening over the phone. So if the person is not properly trained or supervised from a healthcare professional, it could get trickier, because so many things could become like chaotic over the phone. I mean, this is a person, you don't know him, you haven't seen him or her. I mean, it's calling up, saying whatever. This could get trickier. So absolutely, the helpline is absolutely necessary if you ask me. We need to support our patients, but we need to be able to do it like in a very organized, in a very protected way for the patients and for ourselves, but for the procedure also, to have the maximum outcome, the best outcome for the patients and the procedure. I mean, it's someone unknown calling up, talking about anything with so many unknown factors. You cannot go about giving advice or anything. If it's someone with no knowledge, no prior experience, no supervision, this could go so wrong and so quickly. This is why I'm always saying, like, for us here in Eleana, I'm always saying we have to supervise everything happening on the helpline. This is no easy thing to do.
I guess maybe it's a case for different organisations to have a remit for their helpline. You know, they can have different remits depending on what their organisation is. So, for example, Elena has got you've got trained people who can manage more complex calls, whereas for other organisations where it's more volunteer operated without so much training, it's much more of a sort of signposting role, almost more of an information line rather than a helpline, and providing people with that information, but being very, very aware of not necessarily asking or not offering advice per se, and just maybe suggesting, have you thought of going here, have you thought of going there? I know we've got quite a few other questions coming in. I'm trying to work out who to go to next. Mike, I know you had your hand up a minute ago. Did you want to jump in?
Yes, thank you. And following on from what you say, I agree. That's my experience in other organisations. I worked in tuberculosis before, and the support we gave over the phone was very much an information line, not an advice line, and we were very, very clear, and that division is critical. Nadia, thank you. It was a great presentation. You talked about needing to know referral pathways to send people on to. My experience is also that people often come to a health charity when they've exhausted them, and when they're saying, I'm just not getting the help, I've gone back to the doctor, I begged for help, he will not refer me on, people who cannot afford private referrals, and they're just not being taken seriously. We all know about the pain bars with women, that women are more often, you know, told to go away and take some painkillers as opposed to men who are taken more seriously with their pain. How do you deal with situations where people say, I've tried everything, no one is taking me seriously?
So let me again, true story. This is because we are people, I mean, aside from the psychologist, the paid staff, we are, I mean, this patient would be referred to me, to talk to me, because I am a patient, I'm a psychologist, and I do have the lived experience, and I do have the lived experience of similar things. So this patient would be so relieved when hearing a similar, not similar situation, but would be relieved in acknowledging, when someone acknowledges the frustration. And those patients need to, sometimes they need to vent, sometimes they need someone to acknowledge their situation and their history, and they sometimes need to think outside the box, because they say, I've done everything, but in most cases they haven't done anything. They haven't, like, it's the oxymoron of change. They try to change something using the same path, the same ideas, the same ways. They don't go in any other they don't use other resources. And we as a patient organization are there to make use of every resource, if I say it correctly in English. So in many cases, we suggest things that they haven't even come across or even thought about using or trying. So for a particular thing, I'm saying, she said, I've tried everything, I've done everything. She didn't like, she was referred to the chronic pain unit, and the doctors there did acupuncture. She hasn't tried acupuncture, and it worked wonders for that lady, and she was very happy. Like she said, I wasn't even considering acupuncture for chronic pain, and that worked. And another patient, she was like trying to do the mainstream things like yoga, Pilates, swimming, but she never thought of doing another type of exercise, more precise, with a personal trainer, and she tried that. And acknowledging the story, acknowledging the frustration, and making use of all resources, that sometimes is a way to go about it. And they feel very nicely when they talk to someone that actually lives with the disease. They feel better, they feel heard. Some of the frustration stems from that they know that people do not understand what they're going through.
Yeah, absolutely.
And people just because of the, especially those that have been going to from doctor to doctor to doctor with a delay of diagnosis, and having doctors saying, no, it's not that, no, it's not that, no, it's not, it's maybe it's you. I mean, there is a lot of frustration built up, and I've already said about catastrophizing and fear, which are two basic barriers in chronic pain.
Absolutely.
If you address those, you can work with patients.
Thank you, Nadia. Thank you. I know we've had a couple of other people put their hands up, so I'm conscious that we've only got 10 minutes left of that. Brenda, I saw you put your hand up earlier. Did you want to make a comment?
Yes, thank you very much, and I so appreciate the dialogue here. In Canada, we have support groups that we run across the country, transitioned to virtually, and now we're shifting back to a hybrid model. And we have a guideline for that. So just based on today's topic and discussion, we're in the process of updating those guidelines to include de-escalation, confidentiality, privacy pieces. One thing that we don't have in there specifically is what to do if someone is in a personal crisis. So my question is, if anyone has guidelines for their helplines or support groups that captures the essence of this, and if they'd be willing to share, I would really appreciate that.
Thanks, Brenda. Absolutely. I think I wonder whether if there are some organisations that have different guidelines, if any of you are happy to share them, I can potentially sort of share them with the wider group, because I'm sure that a lot of you have got some really, really great information there. Sally, did you want to respond to that?
I was just going to say, we put together a sort of suicide sort of flow chart, what to do if someone then, because I think when someone says, suddenly the conversation takes a very dark turn, and we're all working from home, you can feel quite, anxious. So we've got a little spreadsheet which we have, so we know exactly the questions to ask. So, and then no matter what happens, you think, well, we followed the process. I've done everything I should have done. So I've never used it, but I know it's there, so I'll share that.
Thank you, Sally. That's brilliant. And I think just on that, I think one of the things that Nadia's talked about with the supervision and things, I think one side of that supervision is having, for those people who are manning the helpline, to have time to offload any particularly challenging calls. And I think that is something that's so important for anyone managing a helpline service, is to ensure that anyone staffing that service does have the opportunity in a confidential setting to offload, to talk about, and to ensure that at the end of the day they're not taking all of that home with them. And as Sally says, so many of us are working from home these days. It's very hard not to keep that in your head. So I think that's something that I'm sure that anyone who has got a helpline you do, but I think that's kind of a key part of it. Andrew, I don't know if your audio is working now, if you wanted to try again.
I will try.
Yes, we can hear you.
Yeah, thank you. Thank you, Nadia, very much for the really very informative presentation and talk. In Cyprus, we have a helpline, and we have a psychologist that is working for the league. And also we have a social worker. So first, people are talking with a social worker, social officer, let's say. And if the social officer find out that the person has psychological issues, then the officer is referred to the psychologist. And the psychologist is doing personal appointments with them, either by phone or face-to-face. It depends of the availability of the people. And psychologists traveling all around Cyprus, and is having also on the houses for people that they cannot move. They have appointments in the houses. Furthermore, if both of them found out that the person is need more on talk with other patients, we have groups, patient groups, and with leaders, and they refer them to the groups. But when the groups have meetings, we have always either the social worker or the psychologist to be there with them, in order to ensure that the things are not going out of any issues, like Nadia said, with pharmaceuticals, medicines, and or with any other issues that maybe cannabis, that sometimes people are asking. So we have to be sure that we don't give it, the leader is not giving, or any other of the patients not giving any wrong answers. But what Nadia said on her speech about the chronic pain and how people are getting to the loop and they are not moving around and so on. In Cyprus, we are trying through the groups to motivate them to do gymnastic. We are offering some Pilates, yoga, even music therapies we are doing. And people are trying always to find something different to join in, but they especially need to talk with other patients, because they want to hear how the other patients are dealing with the issues that they are facing on everyday life. And most of the people, when they contact me, because many of them want to speak with me, they are asking me about biological treatments, and they are facing a lot of worries and stress about using biological treatments, and that again we have to be very careful what we are talking about. And usually they are asking about the doctors also. Is that doctor good? Is the other doctor good? And again, we have to be very careful with our answers.
Absolutely. Thank you for sharing that, Andrew. I know a few people have put some really great comments in the chat as well, so take a look through that. We are running out of time. I just wanted to say, Andrew, it's really interesting what you're talking about with movement and exercise classes as well, because you know, we've just run World AS Day on the importance of movement with people with axSpA, and we know that movement can really help to improve people's psychological and emotional well-being as well. So I think that sort of goes hand in hand. Does anyone have a last comment before we close the session? No, wonderful. Well, thank you so much, everyone. It's been a really interesting discussion. I really appreciate the sharing that you've done and the exchanging of ideas. As I said before, if anyone does have any guides or documents, Sally, if you want to share them with me, and I will happily share them with the ASIF members and those people in the group as well. Nadia, thank you so much for your presentation. Absolutely brilliant, really interesting, and look, we loved having you with us. We are always looking for ideas for our next webinars, so if anyone does have any brilliant ideas, please drop me an email, and we can look at what topics we cover in the future. And also, I hope to see a lot of you at the AGM tomorrow. So thank you so much, wherever you are in the world. Good night. Enjoy the rest of your day, wherever you are, and we'll speak to you soon.
Thank you.
Thanks.
Bye.
Bye.